I'd like to make a comment, and I want Kimberly to comment on it. I've been doing asbestos lectures for years, and the issue of intimacy has actually never come up. And I think this is extremely important. It's something in clinical practice. I had the following experience that really introduced me to the depth and need to consider the problem, or the issue of human intimacy in diseases like asbestos-related cancers and plain old asbestosis, which is non-malignant. When Viagra first came out, I see asbestos patients for years and years. We get to know each other quite well, actually, as you can imagine. And one Friday at 3 o'clock, the last appointment of the day, a lady came in who I hadn't seen with her husband, who was my patient, in about 5 years. And I said, what brings this visit today? And she said, we want to try some of that Viagra. So, I was kind of surprised because my usual Friday afternoon is filled with men calling between about 1:30 and 4:30, making plans for the weekend. And, they leave a very brief message. And those of us who take care of any number of men know this to be the case, or those of us who may be men ourselves. But men frequently start planning for the weekend and call on Friday and they'll leave a message, vitamin V, 50 milligrams, call some in, would you, Mike? This sort of thing. So that having been said, I began becoming much more sensitive to this with the emergence of frankly, Viagra and Cialis and Levitra. And then as the intercorporeal injections have emerged for men, this, in case you don't know what it is it's a little 1/4-inch long TB needle. It's very thin, and men can inject into their penises a medication which will evoke an erection, where the oral medications don't work. And it's a lot of wives will say, well, gee, I don't want my husband doing this because I don't want to think about him sticking a needle into his penis. But if you ask the husbands, they'll say, what's a needle? So once in a while I get a wife saying that too, though. So that having been said, Kimberly, I wonder if you could talk about your experience with this broaching this issue of human intimacy and how important it is. The one last thing that I want to say about it is you have to remember that from the perspective of a man who becomes ill with the disease that affects human sexuality, there's an isolation that occurs because of the illness. People with asbestosis who can't breathe, or who get asbestos cancers, or who get mesothelioma who can't breathe, are first of all isolated because they can't breathe and they can't move around and they're in great pain. Secondly, when you remove human intimacy, which you know the studies, I mean, just think about yourself, you know the studies, like men have thoughts of sexuality every 93 seconds or something, and women are generally much longer than that. But I've been married for a long time, so I'm not going to make a guess on how long that is. But men have these recurrent thoughts very regularly. So to remove the well-being caused by the illness, and then to remove the sense of self caused by an inability to be intimate with the woman that the man loves, is an enormous devastation. So do you want to talk about that?
You know, I think my background in this, I started most of my experiences in the cardiovascular world, but when I started doing cardiac rehab is where this all came up, because oftentimes folks that are affected with a heart attack issue or blood flow issue, and oftentimes with cardiac medication, that just inherently distinguishes the sex drive or the physical capability of sexual intercourse. So it was a part of our education series that we would provide this information for our patients. And beginning to work with the asbestos patients, at the CARD clinic, we always look at the holistic approach. And it's not only the fact that we're having breathing difficulties or pain issues or the physical issues of it, but we look at the emotional end of it. And as Linda pointed out, it's not, it's the financial, it's the emotional of how we cope at home. And having that door opened through, talking to them about the psychosocial issues, just kind of segues naturally into that, asking folks, do you feel cared for? Do you feel intimate? Do you have any questions about that? And it's pretty amazing. I mean, I think at our clinic that we would receive the the 4 p.m. Friday phone calls too. Well, Thursdays, because we're not open on Fridays. But, you know, when it started, it's amazing. It's not just men, but it's females too. And oftentimes it's the caregiver that brings it up, in the fact that I care for my husband, yet I care for him in taking care of his, you know, physical needs. And how do I, you know, maintain that intimacy? And so it takes that opens the door for counseling, of helping them to understand, to be assertive and let them know, I'm caring for you, but I want to touch you and I want to be with you from an intimate, on an intimate standpoint, you know, not just to take care of you. The other thing that we try and counsel a lot about is that intercourse isn't everything. You know, there's a lot of different ways that you can be intimate with your partner. I think there's a lot of innovative ways to be intimate with your partner, and it may not be within you know, what we are custom and usual with, but the situation that you're in is not usual and customary. So you have to be creative together and communicate very strongly with each other and openly about what your needs are. So I encourage everybody, because as Dr. Harbert points out, you know, intimacy is a huge part of our well-being, and although that we all think it's behind closed doors, it's a very real aspect to make us whole.
I'm just thinking back about 7 years ago when my husband was ill and subsequently passed away, and I just remember the doctor saying to my 150-pound, 5 feet 9-inch husband, bulk up. And it was just a very, very frustrating time, because this was a guy who ate a half a pack of Oreo cookies every night before he went to bed and didn't gain a pound. And then when he eventually maybe was up like 2 or 3 pounds, he'd stop eating them for a week and he was back down. So this was a man who was not going to gain any weight. But the thing that the doctor said was bulk up. And it was kind of frustrating because we had no idea how to bulk up.
Yeah.
And subsequently what we found out was every time Joe sat down to a meal, it was a death sentence, because he knew he had no appetite and he couldn't eat. And he knew that if he couldn't eat, he couldn't get the surgery. So I think we needed more support from the doctor. We were never given a nutritionist or any ideas. I got a lot of information from ACOR, which is acor.org. There's a mesothelioma listserv when Linda refers to ACOR, and actually that's how I first met Linda. And I would just ask out there, how, you know, what do we do? What do you do? You know, and then, you know, when he was getting his chemo, I mean, and pain meds, constipation was a big issue. And, you know, tell us what to do. I mean, we had no idea what to expect. And I don't know if it's a question, a comment, a statement, or you know, it's just more support is needed, and more patient education is needed, and more communication, I guess, from doctors, because you're right, when you go in and you hear that shocking news, you know, you don't hear. You do not hear. And
Of course not.
you know, you don't know. So I'm rambling, sorry.
Do you want to, Kimberly?
Well, I was just going to say I was going to advocate to put a dietitian on Linda's list of your healthcare team. I mean, we always think of the expertise and the specialists that are going to take care of us in our situation, and we forget about those basic needs. We all eat. We all have emotional issues, you know, and those are the basic things that we kind of forget because we're walking into a whole new medical world. So definitely add that dietitian and nutritionist on your list.
I also think that if you get in a habit of keeping a journal, your own personal health journal as to what your symptoms are, you don't like food, or maybe that you're sensitive to cold, then when you go to your doctor, he'll say, or she will, what's new? And you say, I can't eat, I am constipated, but it's really hard to take in 3 weeks of physical symptoms and then try to articulate them back in a 15-minute visit with your doctor. I think you're better prepared if you keep an ongoing journal. And then you may not know to ask for a dietitian, but if you say, I can't eat, your doctor will then probably suggest that. So we don't have to have every answer ourselves. We just have to be able to ask the right questions, I think, to our medical team. What do I know?
I mean, unfortunately, cancers produce chemicals that cause the body to not want to eat, and then the treatments that we give the patient then certainly makes the patient not want to eat, the chemotherapy, et cetera. And certainly the role of the oncologist is to be that patient's quarterback, to try to focus not only on the how do I treat the cancer, but how do I treat the patient, and how do I take care of the symptoms of pain, of weight loss, of fatigue, of constipation. And so really a good oncologist should be able to do that and should be able to ask the right questions, but we can't read someone's mind. And so indeed it's helpful if the patient is able to provide that with us, for us.
I think Dr. Kindler's right. From my perspective, I think if you don't have a relationship with your oncologist or who's ever supervising the health care at the time of chemotherapy or radiation therapy, where you can say, look, my husband's constipated, he hasn't gone to the bathroom in 2 weeks, help me, or look, he doesn't have any appetite. And if you raise these things directly and forthrightly, not confrontationally, but directly and forthrightly, and you don't get an answer, it's time for a new doctor.
Yeah, those are standard questions your doctor should be asking you. And if they're not, well, are you not communicating, or is it that the doctor isn't the right doctor?
And I also think there's a big advantage of going to a cancer center, like University of Chicago, Carmanis. A cancer center where people are directed toward the aspects of treatment and healing and care. What other questions are there?
Not every patient geographically can, and that patient who can't, because they can't afford it or they live too far away, shouldn't feel that they then can't get good care. But if that patient comes at least one time for someone who can be able to provide advice, and then maybe have that one expert doctor be able to work with the local doctor, that can also work. So I don't want to obligate every patient to have to always fly to see the expert, although that expert should in some way be involved in their care.
Yeah, that's a good point. Thanks.
I have one question for Dr. Kindler. Since you're president of IMIG, how common is it for those doctors to basically, you're an expert in the Chicago, Illinois, actually in the nation, how common is it for you to see a patient and then outsource his medical treatment to a local oncologist, and then you stay in contact? Is that maybe 20% of the cases you might feel comfortable doing it?
Part of that depends not only on the receiving doctor, but also on the patient and their needs. I see patients from all across the United States and actually from around the world. And I offer the patient at the outset the option. I tell them, you're more than welcome to fly back and forth every 3 weeks for your chemotherapy or drive 4 hours, or I can provide the advice and be the quarterback, and then your local oncologist can provide that. You tell me what it is that you want, and I'll tailor it for you. With some exceptions, if that patient really has a doctor I don't feel comfortable with. So I will tell the patient, let me talk with your doctor, let me make sure that that doctor gets it, that doctor doesn't mind taking some direction, but also understand that if you're back in central Arkansas and that doctor has never seen this before, that I can't take care of the absolutely every day-to-day minor issues, because medical legally I can't, I'm not seeing you. So it's an interplay of what that patient wants, what they need, what they can afford to be able to do. Not every patient can travel back and forth.
I think your approach is what all patients want, is what I'm trying to say in a positive way, is they want to be able to go see an expert, and maybe you can't maintain treatment every 3 weeks there, but having you on my team would make me feel better about my care. So that's a progressive approach.
And of course, many patients, once they come and see what they have to offer at a cancer center that has seen not one meso patient every 10 years, but one every 5 minutes, then they actually say, well, Mom, yeah, it's worth it. We can drive you. That's okay. Don't worry about it. And that often does happen.
I think so.
I just wondered, seeing as your health service is going to be altered, and we're from the UK, I just wonder whether you're going to have the same problems as we have, and it depends on which area that you live, on what service that you get from the National Health. To hear you talk, you've got the option of going privately, you have your medical insurance. How's it going to affect you? We've had a lot of problems.
I think that's a YouTube question.
I would actually say that it's going to make it hopefully easier rather than more difficult, because right now, if you have the right insurance and you live in the right geographic area, you can see someone. Whereas hopefully when more people are able to obtain insurance, it will become easier for people to be able to go to places of excellence. And unlike the UK, where each region is given a specific budget and, you know, you can only get a limit if your doctor has enough money for it, that certainly will be nationalized as it already is. So that's not the issue. It's just that hopefully more people will have access to care. And with access, then they'll be able to see who they
I
want.
wish you a lot of luck.
Hopefully. Keep our fingers crossed. Mike?
You know, I think there are a lot of nuances in the U.S. health system that even doctors don't really know about. For example, in the case of hospitals like Carmanis, which are dedicated cancer hospitals, there are a separate set of Medicare reimbursements, which are frankly much more generous than the Medicare reimbursements in hospitals which are not recognized as exclusive cancer hospitals. As surprising that may be. But for example, if a patient's admitted under a particular diagnostic code, under Medicare to a general hospital, the reimbursement to the hospital is less than if that facility were a cancer hospital. So I don't think that's really been addressed by the new healthcare legislation. You know, as a realistic matter, we have a lot of people who fall off the edge here as well, because, you know, I glibly talk about CAT scan, PET scan, you know, $150 blood test, whatever, you know, whatever it takes. But there are enormous numbers of people who walk around growing cancer for 3 or 4 years, but just didn't have the money to go to the doctor. And then they die as a result of, not of the bad system, but they die as a result of greed, because we couldn't figure out a way to give them health care or make it
Hopefully that
available.
will change. Yeah.
So, you know, I don't think there's any perfect answer.